Good afternoon, everybody. My name is Vincent. I'm a Canada Excellence Research Chairholder in Genomic Medicine at McGill. I'm also the director of the COVID-19 Biobank in Quebec. I must say I'm a happy camper or a happy moderator. If I had the luxury of having the best experts in genomic epidemiology and the best experts in ethics and legal in genomics, I would have picked Dr. Rory Collins and Dr. Bartha Knoppers, and both are here today. So it's a great privilege for me to chair and moderate this session. I want to thank you both for joining today. Let me just introduce Sir Rory Collins now. So Rory Collins is an epidemiologist. He studies how to prevent and treat cardiovascular diseases. He is the British Heart Foundation Professor of Medicine and Epidemiology. He is the head of the Nuffield Department of Population Health at Oxford University. And more importantly, for what matters today, he is the principal investigator of the UK Biobank. I think that probably when history will look back, there will be probably a before and after UK Biobank in biomedical sciences. And I think that the vision, but also the generosity of the UK people and the participants of the UK Biobank and their investigators is just remarkable. I attended yesterday the 20th anniversary. It was just a superb event. So Rory, thanks a lot for joining today, and the floor is yours.
Thank you very much, Vincent, and also thank you, Mark Lathrop, for inviting me to join you in this meeting. And I'm only sorry that it's all virtual. Let's hope that we're all back together physically soon. I'm a cardiovascular epidemiologist, as Vincent mentioned, and clinical trialist. But like many of us, over the last 18 months, we've all had to transform into infectious disease researchers in one way or another. And what I wanted to do was talk about the ways in which the existence of UK Biobank and the resources that have been put into it, in particular by the Medical Research Council in the UK and the Wellcome Trust, who established it, provided the opportunity to support a lot of research, including at short notice, research into COVID-19. So I want to set the scene in describing what we had when the pandemic hit. Back in 2006, 2010, we recruited 500,000 people from across the UK in 22 centres, recruiting out to around 50 miles from each of the centres that we set up in different locations around the UK in order to enhance the heterogeneity of the cohort in terms of where they lived, urban or rural, their socioeconomic status, and ethnicity, amongst other things. At that baseline assessment, where they spent 2 or 3 hours with us, we got them to answer many questions about lifestyle, environment, family and personal history, cognitive function. Hearing tests were done, physical measurements, and biological samples of blood, urine, and saliva were collected, processed, and stored. We got explicit consent from all of the participants to access all of their medical and other health-related records. That includes things like occupation and education, to recontact them for further assessments, and for the data to be made available for health-related research of any kind by academic and industry researchers anywhere in the world. So the reasons why the Medical Research Council and the Wellcome Trust set up a prospective cohort was because they felt it was so important to be able to look at the relevance of many different kinds of risk factors, not just genetic risk factors that aren't changed particularly by the development of disease, but environmental, lifestyle, and other kinds of risk factors which are changed. And in order to be able to look at genes, environment, lifestyle, and their interactions, one really needs to have assessed those before a disease can have had an adverse effect and changed the risk factors you're trying to measure to avoid reverse causality. The issue, though, is that The issue, though, is that most people in a prospective cohort won't develop any particular disease. So in order to have large enough numbers of individuals with a particular disease, you have to have studied very much bigger numbers and then followed them long term. But of course, by building it as a resource for many researchers around the world to use, every participant will contribute in one way or another to studying one or more different diseases. So it's very cost effective in the long term, but it does take time before it's mature. And it's really only in the last 5 years that UK Biobank has become mature. This is just intended to illustrate really how big these studies need to be. So these are real data. Back in the 1990s, we brought together data from a large number of observational studies on a total of about 1 million people who had been followed for about 10 years. These were studies from across the world and looked at a strong risk factor, systolic blood pressure, and a common condition, death from coronary artery disease. And then what we did was we randomly selected 5,000 people from those 1 million individuals to illustrate the association between blood pressure and disease. And that's shown here with the point estimates for risk against blood pressure and the confidence intervals around those point estimates. And you can see a kind of general blur with risk going up with higher blood pressure, but you can't distinguish between the risks at different ages or the shape of the relationship. If we then randomly select 50,000 of those 1 million individuals, the confidence intervals get narrower. It's a little bit like focusing a microscope. Things are starting to become clearer. But is there a J-shaped curve where lower blood pressure in younger individuals is associated with higher risk? Is it flat at older ages where higher blood pressure is not associated with higher risk? And that was a view that was held quite strongly based on these smaller scale studies that lowering blood pressure among elderly people may not be beneficial. But when we focus the microscope more precisely with 500,000 people, then we get these beautiful log linear associations. So the y-axis here is a doubling scale. We've become very used to seeing exponential curves plotted over the last 18 months. And you see these lovely straight line associations where the same absolute difference in blood pressure is associated with the same proportional difference in risk at all ages. Because the slope is not as steep at older ages, that means there's a relative interaction, not as strong in relative terms at older ages, but the absolute risks are higher. And so the absolute interaction is the other way, stronger at older ages. Now, this is a common disease, coronary heart disease mortality. This is a very strong risk factor, and still you need 500,000 people to be able to understand the associations. So with UK Biobank, we collected about 55 mils of blood, saliva, and a urine sample. And in fact, nothing so far has been done with the saliva, the tubes that were collected on the last 200,000 people for RNA, or tubes that were collected in the expectation that we might have to immortalize cells in order to get enough DNA. Of course, technology has moved on, and with the buffy coats, we have plenty of DNA to do it, pretty much anything we would want to do. But if you have good ideas for these samples, please do let us know. So when the samples were collected, hematology was done on all 500,000. And then subsequently, following the completion of the recruitment, biochemistry assays were done as well. And these were the assays done on the whole cohort in a random order of the participants in order to avoid systematic shifts over time. So kind of known risk factors for disease, such as cardiovascular disease or cancer, bone and joint and renal conditions. So these data have gone into the database. Ongoing biomarker assays include the Nightingale Health NMR metabolomic data assay, which has now been released on over 100,000 people. And most recently, funded by an industry consortium, 50,000 randomly selected individuals are having the 3,000 protein O-Link platform applied. And we're hopeful that if that's successful, then that funding will be found to do that for the whole cohort. Web questionnaires have been done subsequent to the baseline assessment visit to get more information about exposures. For example, more detailed information about people's occupations, but also web questionnaires have been used to assess health outcomes. We've had repeat assessments of the random selection of the individuals in order to be able to take account of changes over time, so correcting for so-called regression dilution bias, which can substantially underestimate risk. Activity monitoring has been done on 100,000 people, and Aidan Doherty in Oxford has turned those activity monitor data into measures of activity that can be used by researchers. And we're now into the genetic assays, so all 500,000 have been genotyped. But what's the strategy for sample access? Well, originally, what we anticipated was that one would be taking cases of particular diseases, pulling out their samples, pulling out match controls, and doing those assays. But we realized quite quickly that if we did that, we would really weaken the value of UK Biobank as a resource for doing research on many different conditions, because those case control sets being assayed at different times would not be directly comparable. And so instead, what we've tried to move towards is whole cohort assays of a particular set of samples. So it's really up to the research community out there to say, we would like to do assays. In doing so, the Access Subcommittee, chaired by Martin Bobrow, thinks about how valuable will that be for the research as a whole, for all researchers. Need to know the assay method is validated, that it will ideally yield many different measures that are of value to many different kinds of research. It doesn't deplete the sample. It uses high quality assay methods. And as I say, undertaken on the whole cohort or a large random subset, such that if one was then to go on to complete it on the remaining cohort, one would be able to take account of any changes in assay methodology. The advantage of this is that uncontrolled case control assays may well deplete the sample and not be very useful for research across a whole cohort. Whereas I say, by contrast, these cohort-wide assays are cost-effective. You can often get very substantial reductions in the cost, as we found with the genotyping, minimize depletion, improve quality control, use the cohort itself as its own control by assaying in a random order, supports many different comparisons, and yields data that, unlike samples, are much more readily shareable. But of course, this is costly. To do anything on 500,000 people is costly, and therefore finding investment to do that is typically not straightforward. So the first opportunity that came was funding from the UK government to genotype all 500,000 participants, and a genotyping array was designed by a working group of experts chaired by Peter Donnelly, working with Affymetrix, and the data for the first 150,000 participants were made available in 2015, and then for all 500,000 participants in 2017. I think this has been one of the things that really kick-started the use of the UK Biobank resource. When the genotyping data became available, we started to see many more researchers using the data and a shift from its use just in the UK to its use internationally, which has been really very exciting because it's meant that so much more research has been done. And I think one of the most striking findings and something that came out of a piece of work done by a PhD student actually at the Broad, which again I thought was very, very nice, that this resource was available to not just established researchers, but to researchers early in their career, was the identification of the concept of polygenic risk scores. And this is an example from work done by Peter Donnelly showing that as you'll be well aware, polygenic risk scores can identify the top few percent of, say, women with breast cancer or men with prostate cancer or men with coronary artery disease or people with type 2 diabetes, equivalent often to the risks associated with a single gene disorder, such as BRCA1, BRCA2, or in the case of coronary artery disease, familial hypercholesterolemia. So really opening up the opportunities for using these scores to identify people who might benefit from, say, early screening for breast or prostate cancer or colorectal cancer, or early interventions for those at high risk of coronary artery disease. That interest in UK Biobank then led to increasing interest from industry around the potential for UK Biobank to provide opportunities to do research that would help in terms of identifying, in particular, new therapeutic targets. And driven by Regeneron and initially GSK and then other companies, exome sequencing was done on the whole of the cohort. And again, 200,000 of those data were released in the end of 2020, and all 450,000 have been done so far, were released last month, with the remainder, as we mop up the remaining participants, DNA and exome sequencing early next year. And a paper that was published in Science recently, driven by Regeneron, looking in UK Biobank and then in other cohorts, including the Mexico City prospective cohort, identifying a potential target for, down here, GPR75, a therapeutic target for reducing body weight. And then yesterday, based on sequencing that has been going on throughout the last year or so, the first 200,000 whole genome sequences were released to researchers across the world who wanted to access them, with the remaining 300,000, so the whole cohort, being available early in 2023. This has been the progress of the sequencing. It started in August 2019, and this was our target. And you can see that even despite the impact of the pandemic, the sequencing facilities at Decode in Iceland and at the Sanger Institute in Cambridge have managed to keep up with the target and deliver this sequencing project over a very short period of time, so over just 2 years. In addition to the industry investment and the investment from government, the UKRI, the UK government and the Wellcome Trust, additional industry investment is going into making these data more accessible to the research community through the application of various IT systems. And then in terms of the other enhancements that we're doing, the imaging of 100,000 participants. So we have had completed the imaging of 50,000 of these participants before the pandemic hit, MR of the brain, the heart, the body, carotid ultrasound, DEXA, and a repeat of the baseline assessments, physical measurements, questionnaires, and blood samples. And then people have been working on these imaging data and turning them into imaging-derived phenotypes, which are then available to researchers. So there are more than, say, 3,000 brain imaging metrics and more cardiac imaging and body imaging measures being made available to researchers. We are in the process of getting agreement to then bring back up to 60,000 of these participants in order to be able to do repeat imaging of them, to be able to look at change over time. We regularly follow up the individuals through linkage to health records. So for deaths, for cancers, for hospitalizations, and for primary care. And until the pandemic, we were struggling to get access to the primary care data which is perhaps the richest data on health outcomes within the UK healthcare system, because it has all of the information about diagnoses, symptoms, signs, referrals, prescriptions, laboratory data, going back to the 1980s on these individuals. The problem is that each general practitioner, each family doctor is the data controller, and obtaining access has been problematic because of that non-centralized approach for primary care data. These are the numbers of cases that we've seen so far of some exemplar diseases, but you can see that over the next 5 years or so, the numbers of diseases of aging, such as Alzheimer's, Parkinson's, are going to increase very rapidly. What we have also been able to show is how valuable general practitioner data are. Perhaps not for things that get you into hospital, like myocardial infarction, where it adds a relatively small proportion of additional events, but for things like diabetes or chronic obstructive lung disease or depression, mental health, cognitive function decline, the general practitioner data we know is very, very valuable. The principles of access to UK Biobank is available to all bona fide researchers, no preferential access. Researchers only pay for the cost of actually using the data and not setting it up, or the cost for enhancing it, as with the assays. And all that's required is that people put their results into the public domain. We've seen an enormous increase in researcher registrations over the past 15 years. And in approved applications. And you can see the major areas of research use, a shift from 2016 to 2021 with the release of genotyping data towards more and more international use. And what we are hoping is over the next 5 years to increase the use beyond Europe, North America, and into other areas by making the data more readily accessible through a research analysis platform that we have just launched. So coming to COVID-19, having that UK Biobank resource in place, all of those linkages in place, made it possible for us to get very rapid and very frequent updates of data. So we were able to get on a weekly basis all of the PCR tests that were being done by the health service. We were able to get death and hospitalization data on a monthly basis. And under special emergency powers, we were provided with access to primary care data on a regular basis on all of the participants. And we were able to make those data available very rapidly to all of the approved researchers who indicated that they would confirm they would use it only for COVID-19 research. What we're hoping now is the demonstration of that value of the primary care data will allow us to get agreement for these data to be used for all research. We had to close down the imaging centers when the pandemic hit, but it then crossed our minds that we had a unique opportunity. We had 50,000 people who had been previously imaged. We then went back to those individuals and using antibody tests, identified who had been infected and who had not been infected. And we have then invited and imaged 1,000 of the individuals who had been previously imaged and who were infected, and 1,000 matched controls. So we have a resource of pre-infection imaging data on 1,000 individuals who became infected and 1,000 matched controls, and then their the post-infection data and for matched controls, which I think is a unique database for looking at the impact of infection on change rather than on a post-infection only. Those data have also now been made available to researchers to use to look to see whether there are effects of infection on various measures. And I just want to show one example of this is in medRxiv being under review, a paper by Steve Smith, Carla Miller, and Gwen Duad, where they took the first 400 or so infected individuals and matched controls, and looked at the effect on brain imaging. And what they found was that the effect of infection was significant loss in those areas of the brain that were related to olfactory and gustatory cortical systems. So taste and smell. And no other clear effects on areas of the brain other than memory-related regions. And when we looked at the changes in cognitive function between the pre-infection and post-infection, again, they seem to see differences in executive function as a consequence of infection, quite soon after infection. So it would be very interesting to see the longer-term effects. And about 800 different research groups around the world have been using the UK Biobank data. About 200 papers or more have come out on the COVID-19 research within UK Biobank because it was available immediately for this research. We then thought, well, how can we use UK Biobank to look at the long-term sequelae? And so we've found out through antibody testing what individuals were infected. So 200,000 of the participants agreed to do a self-administered lateral flow test and then a laboratory test in those who were vaccinated to determine prior infection. And about those data will now be uploaded in January to allow people to look to see whether previous infection is associated with long-term disease. We've seen big increases in output over the last 5 years, in citations, now in patents. And in conclusion, what I think is special about UK Biobank is the combination of it being prospective, very detailed and increasingly detailed, very large, and that combination really of breadth and depth and now duration, making it useful for all sorts of different research. Thank you very much.
Wow. Rory, thank you very much. I think we could be jealous, but we cannot be jealous because we can just be grateful that you're sharing with resource with the entire world. So thanks a lot. I'm sure there are some questions. Unless there are any, maybe I can take the privilege of moderating this session and ask you, how do you do to keep your participants engaged and continuously providing generosity?
Well, of course, it varies. I mean, some participants are very, very kind of responsive, others less so. And of course, that does complicate the interpretation analysis of the data because you have different kinds of people who respond to take part in additional studies. I think what's been very positive is very, very few participants have withdrawn from the study. Only about 1,000 of the 500,000 have actually withdrawn. And they largely withdrew very early on after joining, went through the visit and then decided that it wasn't something they wanted to do. We've seen a few small spikes, particularly when issues around access to primary care data have been raised in the media, not related to UK Biobank so much, but as related to the NHS, the health services desire, quite rightly, I think, to get the primary care data centrally. But communication, I think, has been very important. Telling people what we're doing, telling people why we're doing it. So explaining to them, for example, why it's a good thing for industry to support the exome sequencing or the whole genome sequencing, what the controls are on the data, what the value is to research in general of that investment. And the response to that, I think, has been very positive, actually.
Thank you, Rory. I may have a question here from Guillaume Bourg from McGill. I'm just reading it. Thank you for the presentation and wonderful resource. To reach out to even more users is the biggest challenge infrastructure or help in navigating the data and doing analysis. So his question is, how much resources are allocated to supporting users?
So one of the things that's really, I think, going to make a huge difference is that as part of the whole genome sequencing project, the Wellcome Trust contributed a £20 million grant to UK Biobank to put in place a research analysis platform. So as the data became so large that really moving the data to researchers, which is what we had been doing, became a limiting factor. The idea was to have a platform that allowed researchers to go to that platform and to work on the platform, on the data in their own area. And so that platform was built in parallel with the sequencing. It's now been launched. We've had a lot of different types of researcher helping us to ensure that it was developed in ways that support their research, but also recognizing that the more it gets used, the more development of it will be needed. And as part of that, this platform was developed by DNA Nexus for us, and it's sitting on the Amazon cloud in the UK. But as part of that, Amazon have offered $500,000 worth of free compute to early career researchers and researchers in low and middle income countries every year. And so what we hope is that that will further democratize access to the resource, because you won't need a big computer to be able to use the UK Biobank data. You'll be able to go to the platform, get as much compute as you want. And as I say, if you're from a low middle income country or you're an early career researcher, you'll be able to do that free.
Thank you very much. Rory, I don't know if there are any other questions. I don't see any in the chat. So if it's not the case, Rory, if you can stay with us. And I can move now to the second presentation by Dr. Bartha Knoppers. Again, it's a great privilege to have Bartha presenting today. Bartha is full professor and holding the Canada Research Chair in Law and Medicine. She's also the director of the Centre of Genomics and Policy here at the Faculty of Medicine and Health Sciences at McGill. We're very grateful to have you, Bartha, and look forward to your presentation.
Thank you, Vincent, and hello, everyone. I must say, after hearing Rory Collins this morning and now, Rory Collins just now and Dr. Bell this morning, I'm just so jealous of countries that have central healthcare systems that make a systemic approach to data collection, data access, data sharing so much easier. Because the story I'm about to tell, and you'll see that I've changed the title from policy and data in the era of COVID to policy data, is actually to show the panoply of different policy approaches to data access and data use. Next slide. So this is my next slide. No, go back one. Go back. Sorry, go back. There should be a table of contents. This is the next slide. Well, there isn't a table of contents. So I'll start by declaring my bias. I'm going to start with what I think we will need, that we need now and in the future, is to focus our discussions on pandemics, COVID, on human rights in order to address the populational public interest aspects of pandemics, and that we have to move away from the traditional legal, ethical, sort of hierarchical norms and dualisms. Next slide. So in order to do that, I'm going to turn to where we really find inspiration, which is in the Universal Declaration of Human Rights. This is just a declaration of 1948. And this declaration led and inspired many covenants. I've only mentioned two of them that I will refer to today: the International Covenant on Civil and Political Rights and the International Covenant on Economic, Social, and Cultural Rights. And this is because as citizens of countries, you can count on the human rights found in various covenants and conventions to be interpreted together so as to reinforce each other. And all of them have their source in the Universal Declaration, which is based on the inherent dignity of the human person. Next slide. So in contrast to traditional legal or ethical norms, they are not social cultural specific. They are universal. So you don't get into those usual arguments about Western ethics versus, Sino-ethics, or you actually are able to have a level playing field of discussion of the nature of these human rights and how they can be used and developed, especially in the area of data access and data collection. So they go beyond a traditional legal and ethical discussions, and they belong to individuals as well as groups. And most importantly, they impose duties on governments and private actors. So they are legally actionable. You can ask your country, why did you not respect this right? Or why are you not fulfilling or developing this right? Next slide. So the human right to science, which I will concentrate on today, which was in the 1966 International Covenant, took the Universal Declaration, Article 27, put it in a covenant, and this is the right to enjoy the benefits of scientific progress and its applications. Everyone has this right. That means everyone, it's a universal right. Note, however, that everyone also has the right to benefit from moral and material interests of anything of which you are an author. This is called the right of attribution. So the right to benefit is in the same article as the right to attribution, to be recognized for your invention, for your ideas, for your originality. And these rights, because they are signed and ratified in legal instruments, and there's 197 countries that have signed and ratified this covenant, can only be limited by law, and only insofar as the nature of these rights are for the purpose of promoting the general welfare in a democratic society. So it's not the interpretation is not a free-for-all. Next slide. Now, obviously, the right to science is instrumental in realizing the right to health. Now, there's no right to health per se, but there is a right to the highest attainable standard of health. But states have a duty to make it available and accessible to all persons without discrimination, all the best available applications of scientific progress. Next slide. So what does this mean in terms of the genome and being in the genomic era? Well, the first theories of justice and genomics for the last, almost since the Human Genome Project, or probably even before that, have concentrated on the inequalities of the genetic revolution. It can exacerbate discrimination, disability, injustices, gender inequality, and so on, rather than looking at whether the genetic revolution can help us mitigate those inequalities by either prevention or changing the risks of such disease in early and late life. So this particular author here says, why don't we develop an account of justice that goes beyond individual rights, equality, cultural, social, political aspects, disability, and so on, to the potential health benefits to both individuals and populations by attending to the evolutionary causes of morbidity and disability. And I could probably put in right there to the evolutionary causes of COVID-19. Next slide. So to close off this first part on human rights, one of the first things that was noticed at the beginning of the pandemic is that pretty well since the beginning of the Human Genome Project, a lot of studies and also clinical medical care were prevented or told by ethics committees not to ask questions about ethnicity, even if it was self-reported ethnicity, because that could be seen as stigmatizing. And with the result that the data sets that we have, we don't know in that sense whether they're truly representative or inclusive of the heterogeneity of modern populations. And that has been definitely one of the first things that was remedied when we began gathering data on COVID patients is to be able to understand, resistance, susceptibility, and target treatments and prevention strategies accordingly. Next slide. So my last slide in this particular first part on human rights and in relation to COVID-19 and in relation to pandemics generally is that in a study that I did with Professor Yatova at Cambridge, we looked at all the reports that countries had put in to the UN since 1966 to see how Article 15 and the right to benefit was being interpreted. And our conclusion was that there was growing agreement that this right to benefit includes in its core content a right to access scientific information, including data and scientific publications, to be enabled by states. So rather than blocking and taking conservative protectionist approaches, this right to access scientific information should be enabled. Next slide. So what's happening? Do the international approaches that have appeared in the last 2 years or so reflect this right to science, this right to benefit, this need to share, or the duty to share even in the COVID pandemic? Next slide. Well, we heard this morning about different initiatives and so on. And I have to say, if I'm not going to make this slide readable because it actually demonstrates that Canada was quite slow off the mark in terms of being able or to submit submissions to GSED, which was one of the initiatives mentioned this morning. So how you treat data, how data is protected, how data is shared, actually affects your ability to contribute to international initiatives that aim to study COVID-19. Next slide. But we also saw that there was a plethora, not only of different, Gavi was mentioned this morning as well, but documents and statements by WHO, by UNESCO, by the United Nations on whether contact tracing, mandatory lockdowns were derogations from human rights, and how could we balance civil liberties against the need to protect everyone in a populational sense during a pandemic. And the derogations that you see at the bottom of the slide, that statement, raise the issue that you could derogate subject to two principles, that of necessity, you had to show it was necessary, and proportionality. The measures had to be proportional to the gravity of the need in a given society. So while there were some statements about solidarity and equity, again raising issues that and principles are often not found in a lot of discourse, came here to the fore as well. Next slide. But as concerns data in particular, this report of April 2021 was quite revealing. A year after the WHO announced an international pandemic, the report came to the conclusion, this is from European Academies of Medicine, the Science Advisory Council in Europe, and so on, that the pandemic has re-emphasized the necessity of international collaboration in research. And it should also act as a stimulus for research and policy communities. We need to re-examine whether current standard procedures of data governance are adequate for making the most of personal data for public health research and action, for public health research and action in a newly uncertain and rapidly changing world. So maybe what we've built might be very good for personal health protection, but not for public health protection. Next slide. So domestic approaches, and I'm going to concentrate on Canada, and I feel a bit like Dr. Rahav, as she said this morning, because what the examples I'm going to use of what we're doing here in Canada, I think I'm going to have to enter into her COVID rehab program because it was an incredible experience. So let's start with the next slide, with the first one that came out here in Canada, almost 6 weeks following the declaration by WHO. And this is from the Canadian Institute for Advanced Research. Next slide. And in this study, CFAR came to the conclusion, particularly with a focus on contact, proximity, and tracing apps that were immediately being suggested as a way of following everyone, counting everyone, knowing where, who, what, why, and so on. And the focus in this particular one, as you can see, included an emphasis on, well, what about privacy if you start, and some states that are more top-down and centralized were successful in using in these apps, such as Singapore, but others found that in their particular society that such apps would not be acceptable. Next slide. Now, this is the Canadian COVID-19 Vaccine Task Force. I think this is the task force that totally did me in, so to speak. This was an incredible learning experience. I mean, I honestly knew nothing about biomanufacturing. I knew nothing about vaccine procurement on a scale of a whole country ordering vaccines and which ones to order, since we didn't know which ones would be approved and which ones would be ready, and so on. But in terms of data, there was also issues of the proprietary nature of these vaccines and how to at the same time respect intellectual property and yet have a public health approach that would make them affordable, accessible, and as we heard earlier, again this morning, globally available. So this was a volunteer committee, almost in military style, as I think we heard from John Bell this morning, but of volunteers that were working around the clock with almost every day in this particular task force. Interesting from an ethical point of view is that being an expert on something, like a former director of let's say a biomanufacturing company or facility, or being an expert at the university who receives money to study X disease or vaccine, seemingly puts you in conflict of interest, at least a perception thereof. And this came up quite often. If you can't have experts because they know something and they've been somewhere in order to acquire that knowledge, how are you going to create what was it called? Something squad, a hit squad or whatever on a particular issue. That's a personal comment, by the way. Next slide. Now, the Royal Society not only put out excellent policy reports and so on to guide Canadian the provinces and the federal government in their decision making on handling, and we saw that this morning in Mona's presentation. They also put out a really interesting, I happen to be a part of this one, series of panel discussions organized by the Globe and Mail. So you really got to talk to citizens and deal with things such as misinformation. What is real data, and can we get it? Do we have it? And why not if we don't? And of course, as Steve just showed us, there was quite a problem, even though the SARS epidemic should have taught us about the need to organize ourselves for data collection. Next slide. Now, the Office of the Chief Science Advisor, Mona's office itself, undertook a study about vaccine passports, vaccine certificates. And again, two particular data issues came up. First, Interoperability Kit. Does the certificate in Ontario, is it going to be valid? Does it have the same scientific value looking at the same data as the Quebec one? Or what if you decide to go to another country? Will it be acceptable because it's actually contains what you need to know that that person has been vaccinated and when and with what vaccine? And that raises privacy issues in terms of being able to find, trace, and follow people, which is what happened in Quebec, the day the vaccine certificate came out, someone managed to get in and on the QR code of several politicians. Next slide. Now, still ongoing, but due to report soon, is the work of the Public Health Agency of Canada Expert Advisory Group on Health Data Sharing. Again, this is an extremely ambitious, hardworking group, and one of the first discoveries that was made was, I was looking at Rory's slide about how primary data from primary physicians came under emergency powers. Well, no one has tried that in Canada. Doesn't mean that you can't use emergency powers. All the public health agencies, provincial and federal one, have emergency powers and measures and are supposed to be legally, since time immemorial, empowered to do surveillance and however defined under their mandate. But access to primary or clinical data is extremely difficult, not only because of the fragmentation that we heard about this morning, but also because data custodians, maybe a bit like the data controllers under the European Data Protection Regulation, actually sit on their data and protect it. So they're not really data stewards, but actually protecting the person's privacy against what could be an actual health need of that person as a citizen in society. So there's going to be some very interesting strategies and suggestions probably before Christmas coming for a new foundation for federal public health data. Next slide. Now, we saw from Steve's talk and other talks that CanCoGen has both a viral and a host genome initiative. The viral is viral data, which is considered to be de-identified data. And you would have thought that being de-identified, that the public health, provincial public health labs would be collaborating, sharing. It took a long time to move and encourage, not coerce, but encourage the public health labs to share data and create this open access portal. But it's now well on its way and hopefully contributing internationally as well. Next slide. Now, we heard from Steve about HostSeq, so I won't go into it except to say that we had to combine genomic with clinical data. And here is where, of course, you fall into the research domain. And when you fall into the research domain, next slide, you get into the medical care settings where any research has to be approved by an REB. And Steve described to you all the different elements that the consent form had to contain. So we didn't have this sort of presumed consent access that was in the UK, and we managed to do it, and it's now starting. But it's complicated. And on next slide, please. When you are also using data from researchers whose research projects are either ongoing and they want to start adding COVID to their research project, or they're in a field that's not only COVID specific, but rather want to create a de novo study in their field and add COVID, not retroactively, so to speak, but prospectively. And as you can see here, this was done in a certain very short time here in Quebec for the Quebec Biobank to actually study what minimal elements would be needed for a biobank. And in that consent, mention the cloud, mention whole genome sequencing, mention you were going to go into health administrative data and ongoing access to medical records. It would be shared internationally. Yes, companies would be using it, hopefully, to develop vaccines and so on and so on. And it's through the ethics committees, but when in that emergency situation, I think they were quite collaborative and cooperative. Next slide, please. So in conclusion, what are the lessons learned? Next slide. Well, we have to move away from our personal autonomy, personal privacy data model when we're talking pandemics, COVID, infectious diseases. And the emphasis that UNESCO's Ethics Commission calling for equity and solidarity had more to do with vaccine availability than it did with the nitty-gritty, down-to-earth issues of collecting, using, and sharing data. But they did mention that the availability of vaccines is, yes, a recognition of the public need and the populational nature, if not universal nature, of pandemics. But it says at the bottom in the third dot on the right, for real equity in the global access to vaccines, we need a shared recognition, ethical recognition of health as a common global good rather than a personal right. And in this sense, health is not only you, but you as a citizen society and the larger, a global society with health as a global common good with no territorial limit needed. But to do that, we need new global legal instruments for economic and political agreements and treaties. Next slide. So there is a call, for nothing less than a reset of global health preparedness and to design a new global health architecture to prevent the reoccurrence of similar crises in the future. Well, this is big, a global health architecture, global instruments, and you can see on the left the incentives and benefits. I don't have time to go into it, of an international treaty on pandemics. Next slide. Why would we want such a pandemic treatment? Treaty. That was a good one. The pandemic treaty would actually, as I said about the convention, it forces states to be accountable and to be actionable. They have to, the rights that are in there are rights that they have to act on and report on. And you could include the duty to share viral data, the duty to reinforce the right of everyone to benefit from scientific progress, the duties of cooperation, and in a human rights framework that is pandemic focused and would help us immediately have those the forum and the focus and the foundation for being able to do a better job internationally of not only being prepared, but to handle the next pandemic. Next slide. However, they're long, they take time, they're negotiated, and then to get states to sign and ratify is even longer. And we can't wait. I think we should start. I'm hoping in the next 2 weeks in this talks in Geneva that this will be put forward as a viable and valid approach. But in the meantime, why are we not looking at the international health regulations that already exist, the WHO health regulations, and see where can we add additional obligations on states? Where can we add additional powers on the WHO? How can we do the funding for WHO to reinforce those international health regulations to encompass and include an pandemic preparedness? It's not on this slide, but there is another UNESCO recommendation that you will hear about in about 10 days that will be adopted on a recommendation on open science. And with the adoption of that open science recommendation, I think it leads the way to reinforcing the international health regulations discussion and perhaps a new pandemic treaty. So to close, I would say we need to shift our focus from avoiding risks, privacy risks, data risks, and so on, to protecting opportunities. And in that sense, through better science, through more accessible data science, also not only preventing, but protecting the health of citizens, everyone, and everywhere, and their right to benefit from science. Next slide, thank you.
Bartha, thanks a lot. When I'm listening to you, I'm always impressed because it's not a helicopter view, it's an ISS view of the world, and also your capacity to deep dive into some very specific questions. So thank you very much. Yeah. I'm sure there are questions, and please send them to me. I take advantage as well of my few minutes to ask Rory, please stay, because after the questions to Bartha, Mark Lathrop has a question for you, Rory. So any questions to Bartha first? So then I may start. So how much resonance do you have, Bartha, with other countries? We are all facing, again, the same challenges. So are you in sync with the others? And what are really the countries which probably have made the biggest impact and understood better these challenges?
Yeah, that's a really loaded sociocultural question. I think obviously we already have international institutions such as the WHO and the UNESCO that already have this mindset. What's difficult for people to understand is that this particular pandemic is, comparisons were made earlier at the beginning in 2020 to the Spanish flu, and people say, oh, well, that went away and everything went back to normal. And I think increasingly countries, when you can see them going back to lockdown or going back to different constraints on the behaviors and freedoms of their citizens, people are beginning to realize that this is not going away. And so we almost need like a new deal, a new way of thinking as citizens. And you will find it in social democratic countries. You will obviously find it in countries with regimes where the state has always decided what you could or couldn't do. But bringing those two worlds together, the sort of freedom, autonomy cultures with their own laws and approaches to handling pandemics to the more top-down, together with the top-down countries that take it for granted what you can tell your citizens to do, is not easy. So we need to use the international fora. I don't think any one country stands out as a shining example of having data policies and access policies and data sharing that we could model on right now. We need to use our international bodies to do that.
That's very helpful, Bartha. Thank you. If you don't mind, I'd like to convey here the question by Mark. So I'm just reading, Mark, the questions that is asking, Rory, the questions that Mark is asking to you. Great work. Could you comment about how you and UK Biobank are stimulating studies elsewhere, Mexico, China, and others in the UK, like the Future for Health? How should countries like Canada advance their efforts in this domain?
Well, I think what's been really enjoyable about the last 15 years of working with UK Biobank is being given the privilege of building a resource that was available to many researchers. Although I'm described as a principal investigator, I've probably done less research on UK Biobank than many, many people. And I think that kind of leverage element, which goes to what Bartha was talking about, these are problems that are relevant to the world. So we need to build resources that are beneficial globally. We have worked with the Chinese Academy of Medical Sciences, helping to set up the China Kadoorie Biobank of 500,000 people in China, with the Mexican Ministry of Health with 150,000 people there. And I think you're going to be hearing about COVID in Africa. But of course, people like Charles Ratimi and the Wellcome Trust and others are looking at how to establish cohorts in Africa. I think we need to recognize how big these studies need to be. people ask me, why was UK Biobank 500,000 people? And I just say, because there wasn't enough funding for 1 million. We really do need millions of people in different populations, so with different exposures, with different disease rates, in order that we are well placed to understand the full range of disease exposures on many different diseases. And I think it goes to what Bartha was saying with respect to COVID-19. UK Biobank was in place. The UK authorities really did act very quickly in terms of making approval for access to data so that it could be used by researchers everywhere. And I think what that has helped to demonstrate is the value of data. And again, it goes to Bartha's comment about perhaps an over-protectionist approach to data, rather than thinking about the loss of not being able to use data. The focus has been on the loss of using it. And I think what we've found in COVID-19, particularly with the primary care data, where we spent the last 10 years failing to get access to those data, is how valuable those data were for COVID-19 research and how low the risk was of making them available. And I hope that what that will do is help to reset. I think this was really what Bartha was saying, reset the balance so that we do think much more about public health impact of preventing access to data, preventing important research. And I hope that UK Biobank will help in that respect as well, in terms of how cohorts are set up elsewhere, because we have to remember that more people died last year of heart disease than died of COVID-19. Tobacco killed more people last year than the SARS virus. We've been having pandemics of many different diseases. It's only the economic and social impact of COVID-19 that perhaps has made people recognize it differently. But I think we have to learn that and apply that learning to all of the diseases that kill people prematurely or disable them prematurely.
It's a very important message of balancing these priorities. So thank you, Rory. Bartha, I've got a comment from Martha Krago here, which I will read to you. Thank you very much, Bartha. I have sometimes wondered about the rights of children in COVID, as governments have made schooling decisions. Yes. Would you like to comment on Martha's point?
Yes, absolutely. The rights of children, till we realized that maybe the pandemic, the treatment, the vaccines and so on should include children, because not only were they being affected, but they were also vectors, and the schools and parents. And just here in my own center, we have more missed work days, health problems that come from the children in the schools than we do from any kind of communication of COVID-19 between staff. Children, I think, have a right to have their actual health and future health protected. I would argue in a public health context that the usual parental authority rules would not apply. It's their own right. They have their own convention as well, as you know, on the rights of the child, that in Article 24 does talk about the right of the child to the highest attainable state of health, including prevention, not just treatment. And so as a child's rights advocate, I think we've been very slow to promote and protect the rights of children in this time of COVID.
Thank you, Bartha. I know that there is a question around also engaging indigenous populations into COVID research and other genomic epidemiology research. Would one of you, Bartha or Rory, comment on this question?
There is definitely, and there has been work, especially here in Canada, with our First Nations and Indigenous and Métis peoples to not only provide vaccines, but also to get the data necessary to understand the different rates or the morbidity, mortality factors and so on with the COVID-19. Because of the data sovereignty of the Indigenous, Métis, and other First Nations peoples, decisions to do something or get data or be able to access or to share data remains in their own hands in terms of their decisions to, once they are engaged, to make their decisions on their own basis, on their own social-cultural basis.
Thanks. I'm so sorry. I would have loved to stay another hour with you two and with the audience asking so good questions. Fortunately, we have to finish up this conversation. As a moderator, it's been a great privilege to moderate this session. But if I may just thank you again both, and thanks the audience as well for their questions and attention. Thanks.
Thank you very much.
Thank you. Bye-bye, everyone.